Hello friends, so today we are going to discuss about the inflammatory bowel disease. At first we will see the complication which occurs, what are the complication occurs during the course of ulcerative colitis and Crohn's disease. Now at first ulcerative colitis. So in ulcerative colitis it causes life-threatening colonic inflammation. So life-threatening colonic inflammation. Now how it occurs? When there is severe inflammation in ulcerative colitis, it causes the release of nitric oxide and it also causes the nerve of the mesenteric plexus to destroy. And these two both effects causes bowel dilatation. And when there is a dilatation of the bowel, that means the wall of the bowel will be thin. And when it goes more than 6 cm, there is a chance of perforation. And if the bowel lumen perforate, then the bacteria goes into the systemic circulations. And which may leads to increased WBC, ESR-CRP and fat. Fat means fever, anemia and tachycardia. These effects occurs. And one advice should be given that daily X-ray should be taken, as if the bowel is more than 6 cm, there is chances of perforations. And in the X-ray we will see one sign that is called thumb printing sign. Now when we will call it severe ulcerative colitis, there is a criteria, True-Love-Witts criteria. So if the patient has more than 6 times bloody diarrhea per day and the blood is 3+, so more than 6 times bloody diarrhea per day and fat, fever, anemia, tachycardia and ESR-CRP, then increased ESR and CRP, tachycardia more than 90 beat per minute, anemia less than, and hemoglobin less than 10 gram per dl, fever is more than 100 degree Fahrenheit, and within these 4, if there is presence of 1 and this point is also present, then it is called the severe ulcerative colitis. Now colon cancer. The second point is colon cancer. It also associated with ulcerative colitis. Suppose this is the lining of the large gut, and these are the villas and the deepest part is the crypts. So when there is inflammations, then it causes inflammation of the crypt, that means cryptitis. And it also causes the inflammation of the glands. In the glands there is the goblet cell, and these goblet cell lose their mucus into the lumen. When the goblet cell lose their mucus into the lumen, the whole gland is distorted. So at first inflammation of the crypt means cryptitis and inflammation of the goblet cell. When the cryptitis occurs, it may lead to cryptapsis. And when goblet cell inflamed, then they lose their mucus, the cell lose their mucus and the whole gland become distorted. So one clinical feature that passage of mucus with rectal bleeding. It is the also feature of proctitis. Now the whole things or these two things causes the damage of the cell and when there is a damage, the cell try to regrow. And when this thing repeat, that means if the long-standing chronic inflammation occurs, when it remains in the long-term chronic inflammations, there is also damage and cell growth. This thing repeats, which may lead to cellular dysplasia, nuclear atypia, and mitotic division, and resulting in the colon cancer, which occurs in ulcerative colitis. And to detect the dysplasia, there is a test, that is pancolonic chemoendoscopy, which replaces the colonoscopy. And this endoscopy using indigo carmine and methylene blue. This dye is used in pancolonic chemoendoscopy and which replacing the colonoscopy. Number 3, hemorrhage. It also occurs in ulcerative colitis if the artery erosion occurs. So it causes hemorrhage. Number 4, it is fistula. The fistula often occurs in Crohn's disease. So as in Crohn's disease, we know there is transmural deep ulcer, and when the muscle layer is also involved, so there is only serosa remains, and as it remains, then the fistula easily can occur. So in Crohn's disease there is the occurrence of the fistula. So which are the fistulas? Number 1, enteroenteric fistulas, means large gut there is a connection between large gut and small gut. So it causes the bacteria of the large gut comes to the small intestine, which is resulting in the blind loop syndrome, and it also causes the diarrhea and malabsorption. Then enterovesicular fistula. Enterovesicular means intestine with the vesicle means bladder, and it also causes UTI and pneumaturia. Then enterovaginal fistula means gut with the vagina, and it causes vaginal feculent discharge. So feculent vaginal discharge. Next, another things occur that when the bowel fistula and sinus occurs, both result in perianal and ischiorectal abscesses. So it is the complication of fistulas, is the complication of the Crohn's disease. We know. Then another complication is malabsorption and stone formation. So when Crohn's disease occurs in small intestine, it hampers the absorption of food particles. So we know Crohn's disease occurs mouth to anus, any part of the GI tract. When it occurs in the mouth, it causes mouth ulcer, and usually it occurs at the intestinal ileum, small intestine and last part like ileum. And this ileum is necessary for the absorption of the bile salt and vitamin B12. So when the Crohn's disease occurs in small intestine, it may causes the reduced iron absorption, as a result microcytic anemia, and which will be diagnosed in CBC by seeing RBC level goes down and MCP also goes down. Next, the ileum. Then there will be the reduced absorption of the vitamin B12 and also vitamin B9, that may lead to megaloblastic anemia and macrocytic anemia. And in CBC we will see the RBC goes down but the MCP goes up. Now the bile salt. Bile salt is the important factor. It causes many things. Usually 95% of the bile salt goes back into the liver and by enterohepatic circulations. But when there is a severe inflammations, due to the severe inflammations, the cell become destroyed. So there is a reduced, or there is a hampers of the bile salt absorption. So most of the bile goes into the large gut, and it causes it becomes a toxic salt. Okay, it becomes a toxic salt. So when bile goes into the large gut, it causes the secretion of the water and also electrolyte from blood to the intestinal lumen. So when water comes and electrolyte also comes with the bile salt, it causes watery diarrhea and also electrolyte loss. So watery diarrhea and electrolyte loss, it occurs in the Crohn's disease. Number 2. Usually bile salt goes into the liver by enterohepatic circulation, and we know that in the bile there is a bile salt and cholesterol. And they remains at 1:13. Like 1 bile salt is for 13 cholesterol. Now if the bile salt is reduced, bile salt absorption is reduced, so in the bile there is a less bile salt. So when there is less bile salt, the cholesterol level will become high, relatively high, and it may lead to the formation of cholesterol stone in the gallbladder. So it causes gallstone. And if there is reduced bile secretion, it also causes less emulsification of the fats. So when there is less digestion, it also causes less absorption of the fat. When there is less absorption of the fat, it causes the fat comes into the stool more and reduce in the body. So the body weight will be lost and steatorrhea will occur. And another one important thing, that when we know that the calcium oxalate, usually oxalate binds with the calcium and it eliminated through the feces, and this calcium also bind with the bile salt. So when there is reduced absorption, the bile salt goes through the lumen, and this extra bile salt binds with the calcium. So when they bind with the calcium, oxalate become free, and these oxalate absorbed through the large gut, and these oxalate precipitate in the glomerulus, which may lead to kidney stone. Oxalate stone means kidney stones. So these are the effects. So if we tell the effects are: when iron absorption lost, microcytic anemia. When vitamin B12 and 9 absorption is reduced, it causes megaloblastic megaloblastic anemia. When bile salt absorption is reduced, it causes 4 things. Number 1, watery diarrhea with electrolyte loss. Number 2, gallstone. Number 3, renal stone. Number 4, steatorrhea and weight loss. And we know that there are some diseases that can causes the reduced absorption of the bile salt and vitamin B12. So what are the diseases like Crohn's disease, ileocecal TB, then ileal resection, and also celiac disease? In these cases, there is also some clinical features. And in Crohn's disease, there is another thing occurs. When there is more inflammation, it causes the stricture. It causes the stricture of the gut. And when there is a stricture, the feature will be constipation, vomiting, abdominal pain, and abdominal distension. Next, bone inflammation. If there is Crohn's disease associated with HLA-B27, then it causes metabolic bone disease. And metabolic bone disease, and the features are large joint arthritis in active phase, then sacroiliitis and ankylosing spondylitis. And in both ulcerative colitis and Crohn's disease, it affects in the eyes. So what causes at first? Either conjunctivitis, number 2 episcleritis, iritis, and uveitis. And in the mouth it causes mouth ulcer in the Crohn's disease. Then liver, gallbladder, and duct. So in the liver, it causes fatty liver disease and liver abscess. And there is also occurs autoimmune hepatitis. And when there is inflammation along the duct, it causes primary sclerosing cholangitis, and which then leads to cholangiocarcinoma if it occurs in long standing, and it is the main feature of the ulcerative colitis. It occurs in the ulcerative colitis. And in the skin, the both ulcerative colitis and Crohn's disease causes erythema nodosum and pyoderma gangrenosum. And one more thing, in the IBD, the macrophage becomes activate in response to bacteria. So when the macrophage become activated, they releases some cytokine like chemokine like interleukin 1, interleukin 6, and TNF alpha. So in IBD, there is release of interleukin 1, interleukin 6, TNF alpha. In response to bacteria, the macrophage secretes these things, and these things goes into the blood and causes increased activity of the procoagulant enzyme. It causes increased activity of the procoagulant enzyme and increased express of the von Willebrand factor, which may lead to clot formation. And this clot causes the thrombus, which may occurs in the venous or arterial, and the venous thrombus may be in the portal vein or mesenteric vein. So venous thrombi occurs in the IBD. So we give the subcutaneous, we give the low molecular weight heparin in this patient, as there is a venous and arterial thrombi occurs. Thank you for watching. Assalamu alaikum.